You're listening to the Turn Autism Around podcast, episode number 180. Today, we are doing a classic rebroadcast podcast with Dr. Michael Murray, who is a psychiatrist, and he is Lucas's psychiatrist. And this is a rebroadcast. The podcast episode was number 28 in the past, and we are replaying it. It is probably my most referenced podcast ever. I love this podcast, and Dr. Murray has really made a huge impact on my life and the life of Lucas and so many other patients. So in this episode, we talk all about when medication is appropriate. We talk about doing a swab test to see what kind of medications might be helpful or actually cause problems in kids. We talk about Lucas's medical issues and some of the medicines and supplements he's had along the way. I think it's just a great episode. I'm so happy we could bring this back to you. Here is Dr. Michael Murray, who is a psychiatrist, talking all about medications and autism. Welcome back to another episode of the Turn Autism Around podcast. I'm your host, Dr. Mary Barbera, and today I have a very special guest, our first medical doctor guest, Dr. Michael Murray, who is a child and adolescent psychiatrist and the Director of Autism Services in the Department of Psychiatry and the Medical Director for the Autism and Developmental Disorders Clinic for Penn State Health in Central PA. His clinic provides care to both children and adults with autism through the lifespan and is staffed by a multidisciplinary team, including behavior analysts. I know there's many listeners out there that are behavior analysts. Dr. Murray's research interests include co-occurring mental health conditions in adolescents and adults with autism and interventions aimed at improving social cognition for adults and adolescents with ASD. I met Dr. Michael Murray more than a decade ago, probably in 2004, when our sons, both about the same age, both with autism, attended the same private school in Pennsylvania. And most recently, about 5 years ago, Dr. Murray became Lucas's psychiatrist. And before we get to welcoming Dr. Murray, I have a disclaimer on my website that my podcast, my video blogs, my book, all the information, even within my paid online courses, is for informational purposes only. And today we're really going to dive into medication use for children with autism and the main medication that helped Lucas. But just because it worked with Lucas doesn't mean it's appropriate for any of your children or clients. So we do want to give the disclaimer that we are not giving any kind of medical advice here, just information to try to get the word out to help kids reach their fullest potential. So I am very pleased to welcome Dr. Michael Murray. Thanks for being here.
I'm glad to do it.
Great. So I'd like to get started. We have about half professionals and parents listen to my podcast every week, and I'd like to get started by describing your fall into the autism world, or in your case, maybe the world of psychiatry, and then how you kind of ended up being more focused on autism.
Yes, sure. So I went to medical school knowing that I wanted to do something with children, and it's particularly aspects of development with children. So initially I thought that was going to be developmental pediatrics or something like that, but kind of going through medical school, really child psychiatry was the thing that really grabbed my interest. So I was in my residency as becoming a child psychiatrist. That's a 5-year residency. So halfway through it, about probably my second year, actually, our son Brennan was born. So I was well on my way to being a child psychiatrist when we were having our first child, and kind of noticing that there were some differences in his development, and kind of trying to understand what his needs were, as they were emerging, it really became clear to me that he had autism. So, kind of the intersection of my professional life and my personal life happened really when I was still training to be a psychiatrist. So obviously I wanted to learn everything I could about autism. So this was, so Brennan, like you said, Mary, Lucas and Brennan are about the same age. So this was the early to mid 90s when we were, trying to figure this out for Brennan. And gratefully things are changed around here. But back then it was difficult to find people who felt comfortable providing services to people with autism, particularly young children with autism at that point. So it was a real struggle. So, just naturally trying to do well by my son, it kind of led to me trying to find out everything I could and kind of verse myself in autism. And over the years, it just grew and grew and grew to approximately about, I would say 12 years ago, my entire professional life has become caring for people with autism. So that is what I do clinically. That's what I teach about. That is what I do my research in. So, my entire professional life now is about autism. And thank you for that nice introduction. You kind of summarized some of my professional interests. So people have a sense of what we do. And that's how, I guess, we got reconnected, about 5 years ago when we were able to start working with Lucas.
Yeah, which I really didn't even know I wanted a psychiatrist at that point. Lucas was having problem behaviors, aggression and self-injurious behavior related to having headaches and having a startle. When he'd get startled, if a fire alarm would ring, he would have self-injurious behavior where he'd bite his knuckle or hit his head, and or even just a little startle, like somebody walked past his desk and accidentally kicked a metal trash can near him. So it was just a really hyper startle. And so I didn't know if it was a seizure. I didn't know, and then if he'd get a headache, he'd be screaming, saying head hurts, banging his head. And even though I'm a nurse and a behavior analyst, my husband's a physician, just trying to get to the bottom of why he was aggressive when startled. So I got a neurologist. I got on your waiting list and a neurologist. We ruled out seizures. It took, I don't know if you know this or know at the time, but your waiting list was like 18 months. I kind of forgot I was even on the waiting list. And, and so then they called and they're like, Lucas can see. And by that point, it was kind of like, I had Lucas on Risperidol and had him on just a bunch of different things, Remeron. And over the years, we tried different things for different symptoms. I didn't keep good records back then, so I didn't really know what they were used for, what the dosage was, how much he weighed, what the side effects were, why we stopped it, why we started it. It was like this maze of like 10 meds that I had used from various doctors. No psychiatrist, I don't think. I don't think he ever went to a psychiatrist before you. But since we had met at the private school years before, and I have some friends that their kids go to see you. So I was like, you know what, maybe I'll try a psychiatrist. But I was really like hesitant to come to a psychiatrist because of kind of what was floating through my head. Like, psychiatrists are just going to order Abilify or Risperidol or some of the standard drugs. And this is like a startle and a headache. And like, I don't want him on like some psychotropic drug all day, every day, 24/7, because he's only having this sporadically. Anyway, to make a long story short, you helped tremendously. And one of the drugs that really helped him ended up to be prescribed by you, but ended up to be a cardiac drug. But before we get into what that medicine is and how you got started even prescribing that, let's talk about, there seems to be a lot of confusion and controversy over treating kids with autism with medication. In general, what are the symptoms and issues that kids and adults with autism take medicine to treat? What in your experience has been the common issues and the common things that medications are prescribed for?
Sure. So there are two medications that have FDA approval for treating conditions related to autism. So there's no medication for the core symptoms of autism. I think that's really important to understand. We have not evolved our understanding of the causes or the pathophysiology of autism to the point that direct medications to target those core symptoms. So everything that I will talk about for the remainder of our time together is talking about the issues that are kind of circle around autism, like so some of the things that kind of go along with it, or are means of dampening some of those core symptoms to allow other treatments to become more effective. So like behavior analysis, right? So sometimes you are having someone in such a state that they're not able to learn effectively, and really kind of creating an internal sense of calmness or relaxation so that the behavior strategies or trying to teach new skills has a better chance of being successful. But the two medications are, you mentioned them, are aripiprazole or Abilify and risperidone or Risperdal. And they both have indications for treating severe mood irritability, severe aggression, and severe self-injury. But they would not be the pattern that you were describing for Lucas, right? It would be the pattern of having them very frequently every day to a degree of really concerning levels for safety of the individual or those around them. So really, if you're thinking about those medications, we would be really looking for frequent occurrence of these behaviors across settings, to a high degree of intensity, because as you also mentioned, they do have side effects which are concerning. So it's really needing to do a very careful cost risk benefit ratio in trying to make sure that there's enough potential benefit to justify the risk that you are going to take on by utilizing these medications. However, just because there's only two that have this FDA approval doesn't mean that we don't use other ones and can use them quite effectively. So I think it's important for professionals listening and for families to listen who are listening is just because someone has autism doesn't mean that they can't have any of the other things that we could all suffer from as well, like depression, like anxiety, like ADHD, right? So people with autism have those things, and in some cases they have them more commonly than people who don't have autism. So, those are the things that we're frequently monitoring folks for. Particularly as people age, there's much more likelihood of them developing depression, much more likelihood of them developing anxiety. So we want to make sure that we are looking at those things. Are they developing to a degree of severity that really maybe a medication can be helpful for them? And then, there are, like we were just talking about a minute ago, is really kind of thinking about things that may be interfering with other types of treatments. So, if you have a really effective behavior strategy, or, you feel like you've kind of gotten to a certain degree and now you're plateauing, and now, what can we do to, try and keep the progress going? Those are sometimes we think about, situational anxiety, right? So is the anxiety progressing to the point in a demand situation where, new skills or new environments are being, the person's being exposed to those, that, the anxiety is rising to the level that's really interfering with them continuing to participate in learning and persisting through that. So sometimes we're looking for medications that are just meant to augment the other treatments, that are making the other treatments more likely to be successful. Obviously, anytime you're looking at a medication, you want to do a very careful analysis of what you think the potential benefit is versus the potential risk of being exposed to that medication. And I love working with behavior analysts because you can always, say, okay, let's think about what this is going to look like behaviorally. So this is what I think is going to be happening in the brain with me utilizing this medication, or in the body. And so if we think about what this is happening internally, what is it going to look like externally, right? So what do we expect to go away, right? Is there interfering behaviors? Are there challenging behaviors? Or vice versa, what are skills that we think are going to progress more rapidly or start to emerge? So kind of looking at a very kind of having clear operant definitions of behaviors that you expect to change as a result of the medication exposure, and then working with them to, okay, how's the data going to look? How often are you going to collect the data? And I think also kind of working with the psychiatrist also can be really helpful, in asking what is the expected window of activation for this drug, right? So if the medicine's not expected to work for 4 to 6 weeks, taking data in week 2 isn't really informative. I mean, unless you need the data for something else, but if you're looking at it for just looking at efficacy of medication, it's too soon, right? So, if you got good baseline data, then you need to wait until week 4. So, I think it's just kind of having that dialogue between the behavior analyst and the psychiatrist is really important and I think impactful in each of them doing a better job. So,
yeah, I think that's a great explanation. And I think as a registered nurse, I think one of the things that lay people don't understand, and a lot of behavior analysts and teachers and people that aren't are professionals but not medical professionals, is that each medication has a half-life and those sorts of things. So it's like how quickly they get absorbed in the body, how long they stay, how long they work, short acting versus longer acting, and like you said, some drugs really to reach their therapeutic dose and to be like working is sometimes weeks, and that's really hard. And sometimes it's very short acting drugs that right. So it's not just a matter of I give my child a pill and then 10 minutes later things are better. I think
right.
that's
I mean,
common.
so there are some medications that do work within hours to days, but that unfortunately it's the exception rather than the rule, right? So most of the medications that we're looking at affecting the brain, affecting mood, affecting behavior, they take time because they're all working at receptors within the brain, and you need to modulate those receptors gradually over time, because if you modulate them too quickly, then you can create pretty significant side effects in and of themselves. So it is right. all kind of, being careful about what we're doing, so we, using the brain, looking at the brain, you always want to be extremely cautious about how you're modulating that.
Plus, like you're talking about modulation, like starting with a low dose, making sure there's no side effects, going up on the dose. And it's really titrating that dose to see how much the child needs, because just because somebody's 100 pounds or 200 pounds, they can react differently to different. So that's the other thing is like, now I know, and I know, every time I come to see you, Dr. Murray, I bring our calendar with the data, which, I talk about in my 3-step guide. I have a free 3-step guide at marybarbera.com/join. And I talk about keeping data. So if we're switching from, Prozac, whatever milligram, to Prozac, a higher milligram, then that goes on the data and that goes on the calendar. Yeah. And then that's part of the record, because in the past, even when I was a behavior analyst and a nurse, before I had my calendar system, I'd be like, yeah, we tried Remeron. I don't know what dosage, how many pounds he was, what we started it for, why we stopped it. But, and that's where, even on your end, is like, to have parents keep good data about the medications that have been tried, I'm sure is really helpful.
Yeah, no, all those things that you just pointed out are extraordinarily helpful, right? And, once again, having data to support, like let's use your Prozac example. So 10 milligrams of Prozac, and we saw a rate of challenging behaviors at this, increase into 20 milligrams, really kind of is that rate of behavior changing as would be expected or not? That's such valuable information, because we're all human, right? And if you happen to have a bad morning, with your child before going to clinic, what are you going to talk about? That bad morning, right? And, and what can be wiped out is 3 weeks of really great behavior, because it just so happened that the day of the visit, it was a really challenging day. And you're going to, everyone, right, is bias, recall bias, right? We just recall what's most standing out in our mind, and we tend to focus on things that really stress us. That's, all of us do that. So kind of having that data, as you're suggesting, and having it, ongoing and over time is really, really helpful. Just one thing I would add to what you were suggesting about, weight and time, and, is also combinations of drugs. So because you try one drug, but there's these other two that are along for the ride, and it seemed like it didn't go well, but if these two are gone, now, it's a whole new story potentially. So kind of keeping track of what drugs may be and it can be anything, antibiotics, supplements, right? Vitamins, everything, right? So we really want to be mindful of potential interactions with medications, because something that is seemingly benign as, zinc supplementation could overthrow the absorption of other medication. And that medication, it didn't really work. Well, because of the zinc supplementation, it really didn't get absorbed as you would expect. And to have it work, you would actually need a higher dose because of the zinc supplementation. So all that information is incredibly valuable for medical providers as they are trying to really make well-informed decisions and give you good advice as to what makes sense to potentially think about.
Yeah, I think that's great. And I did do a video blog a few months ago. I think it's called something like, Should You Medicate Children with Autism? And in that video blog, I talk about Lucas's journey with medications. Like, he took a multivitamin, for instance, and he would get irritable within 20 minutes of me administering the multivitamin. It turned out that there was copper in there. And then I, with more research, figured out that the copper to zinc ratio is affected in some kids. And so then we started zinc supplementation and got rid of anything with copper in it and his mood and everything. So it could be something benign. I'm glad you mentioned multivitamins. It doesn't have to be these, hardcore psychotropic meds. It can just be a supplement or something that you think could do no harm, can be harmful. And one of the recommendations in that video blog is also that if you're not a medical professional treating a child with autism, you should not be saying that kid needs meds or you need to up those doses. And, because it's complicated, as you and I both know, it is very complicated. And it's not just a matter of get that kid on medication, he's out of control. Because if you don't have a good behavioral program, I remember when Lucas was diagnosed, the developmental pediatrician at Children's Hospital in Philadelphia said to us, we asked about medicate, do you medicate? And he said, we do use medications. But his advice, which I think you would agree with, is after a good behavioral program is in place first, ideally for a 3-year-old, with a new diagnosis, get the behavioral program in place, get instructional control, see how it goes, and then we can treat symptoms. But let's not, just put medication on board to further complicate the situation, especially before you even know what positive reinforcement is.
Exactly. Medication should never be a standalone treatment for someone with autism.
Yes.
It should always be part of the package of treatments that an individual is receiving. Yes.
Okay, so let's get back to when I brought Lucas to see you, and this was when he was 18, and I was a little leery because I thought you were just going to recommend something that, I had seen multiple doctors. I had crossed state lines. I had gone to a number of physicians, and I felt like I was just on spinning my wheels. So I got there, explained the whole thing, and, he gets startled, he gets headaches, he has self-injurious behavior, he has aggression. By this point, he's over 200 pounds, so aggression is very scary. He's 18 years old or nearly 18. So I was really relieved because you call like a couple months before or after he turned 18, and I'm like, please don't tell me he just sees children because I've been on this wait list. Now he's an adult. So I was very happy that you saw adults too. But anyway, I come to you, I explain the whole situation. I was exhausted by even telling you the stories. And then you're like, okay, is that it? I'm like, yeah, I'm like, waiting. And you said, okay, I think I know what the problem is. And I was like looking at you like, you know what the treatment should be. Like, I was just like, I have been to like 14 doctors in the past, 5 years, and like no one has ever really even helped me or said they could help me. So you said that it sounds like it was an autonomic nervous system dysfunction, like a fight or flight reaction. And,
Yep.
And this made total sense because as a child and even throughout my life, I've had a problem with feigning, with vasovagal response and feigning. So I actually, when I'm stressed or in pain, I have a chance of going out flight, like passing out flight mode, where Lucas, you explained that he gets stressed or in pain or startled, and he actually goes into fight mode. It's just like, I'm thinking like when you go to see a really scary movie and you just can't stand it, like you might squeeze the person's hand next to you, like that's like a fight mode. Or you get blood drawn, and you might squeeze the person's hand, like, because you just can't stand the pain. That's kind of the fight mode. And the way I'm just trying to explain it because I think it's really important. So anyway, I was like, that makes total sense because I have the flight mode, and that sounds like what my data is showing with the headaches and the pain. And that's when he really, 90% of his instances of startle or of self-injurious or aggression are related to startle or pain. So then I was like, okay, is there a treatment? And you said, yes, there is. It's actually propranolol, which is Inderol, which is a cardiac med, a beta blocker. So how did you come across this? I mean, not many psychiatrists, and trust me, I've told a number of people that have kids that are, having pain or startle or highly aggressive sporadically. I've told them about Inderol, and there's not much research on it. And so how did you kind of stumble upon this as a treatment, and are you using it a lot now?
Sure. So, so you did a great job of describing, what that is.
Thank you.
So probably, we've been working together with Lucas about 5 years now, I think.
Yeah,
right?
he'll be 23
Probably
in the next couple of weeks.
Wow, my gosh, where did time go?
Yeah.
So, but probably 2 years before that, Mary, I was at a conference for something called the International Society for Autism Research, INSAR as everyone calls it. So researchers from around the world, come every year, and this past year was just in Montreal, which is a great meeting. But I went to this presentation by David Beversdorf. So he is a psychiatrist and a radiologist, which is an interesting combination. And he works in the University of Missouri, and he works with people with autism. And I went to it because he is also interested in social cognition, which is one of my research areas, and interested in social cognition in adolescents, which is my particular area that I'm very interested in. So I went to his presentation, and at the very end of it, he just kind of said, and we're doing some really interesting work with propranolol, and it seems to be improving social cognition, but I don't have time to talk to you about it. But if you have anyone who, is kind of struggles with, intermittent, high degree aggression, or, this is something you should be thinking about. And he kind of ran out of time, and, so it kind of was, so I stalked him like at the meeting, like I need to understand this more. So, and he was great. He's a great guy, and we've got to know each other over the years since then. But, so we went out, and, I think we grabbed a beer, and he was telling me about this, and he started to explain about this autonomic dysregulation that people with autism are particularly vulnerable to. And, so the autonomic, is a part of our nervous system that works automatically without us even thinking about it. So, it's what regulates your heart rate, it's what regulates, your skin temperature, how fast you're breathing, muscle tension. So all your stress responses are, mediated through this system. And there are two branches to it. So there's the parasympathetic and the sympathetic. So the parasympathetic branch of that larger system is meant to kind of keep our bodies in the rest and relaxed state. And for a number of years, there had been, in the literature and the research suggesting that people with autism don't have enough parasympathetic activity, and therefore they get upset too easily. And there are certainly people who do fit that pattern. And then there are people who definitely have an underactive parasympathetic system, and that is the mechanism to treat for them. However, what he says, what people are missing is, but there's a really important subset of folks who have the sympathetic over arousal. So the sympath is what you just described, the fight or flight response, right? So what is your stress response to and he was talking about how they get triggered too easily, too strongly, and they don't habituate, meaning as you were just describing, we kind of get that initial stress response, but then we can kind of bring ourselves back down to centered and calm ourselves back down, because that doesn't happen. They stay in that heightened state, and then it's just one insult after another until they just tip, and then they are really kind of losing control. And as he was talking about this, I'm like, this seemed to describe so many of the patients I was struggling with to figure out how to support them and how to help them, right? As you were describing, people who have these very intermittent, challenging behaviors, but when they happen, they're very intense and very frightening. And but at the same time, having our traditional treatment isn't really helping. Trying to help with their parents' sympathy, that's not helping. He goes, we're missing these guys, he said. And, so he's a great speaker. He's one of these Renaissance researchers. So he does imaging studies, he does mouse models, he does clinical trials. I mean, he's just a really,
and what's his name again?
David Beversdorf. And I sent you a link to one of his talks for people who are super want to get deep into this.
So, and Dr. Murray, I asked him to send us some links to some more information hopefully we'll have physicians, psychiatrists, neurologists listening to the podcast, as well as interested parents and behavior analysts and teachers. And we will link this talk by David, as well as some other links to some PDFs about propranolol. And hopefully that is going to help get the word out. But continue. So this is...
Yeah, so that's how we found out about it.
Yeah. So when Lucas was 18, I remember you describing this is autonomic nerve, and I was a neuro nurse too. So that made complete sense. I'm like, this makes complete sense. And I can't believe they're treating him with a cardiac drug. And okay, so we had to up his dose quite a bit from when we started. Yeah. And then we also tried, because he was on 3 times a day, this Inderal. At the same time, he's trying to transition to workplaces, and he's still in school, so nobody can give him his midday dose. And so we tried long-acting Inderal 3 separate times, and it was like he wasn't even on it. He just went berserk. Right. So now he's on 4 times a day Inderal, which, it sounds like a lot, but literally everyone who knows Lucas, Inderal has really saved us from a lot of issues. Because when you get a 200-pound person who's aggressive, who has autism, it doesn't end well. There's not a lot of people that will care for somebody that can hurt people, and there's not places even if I wanted him to live outside the home, he still lives with us, but even if I did, with aggression and stuff, it's really hard to find anybody that's willing to and able to care for him. So it's really life or death to find out a good treatment when you have a highly aggressive or self-injurious kid.
Yeah, no, I think the safety issues are, any parent, right? It's first and foremost on your mind. And unfortunately, there's really tragic stories in the news about how, an individual with autism is exhibiting aggressive behaviors. First responders who are called to, help them in that situation aren't understanding their needs and misinterpreting behaviors that they're displaying. And like you said, they can end quite tragically. So having a sense of being able to support someone in their most challenging moments so that they can, utilize other coping mechanisms or verbalize what they need, or, have, the opportunity to have their body not betray them, right? So that they can tolerate that alarm going off without their body feeling like, that they're, really about to die. That's what it feels like to them.
And you've also gone on to treat other individuals with autism that don't have that fight or flight, but do have like anxiety and social issues and like a different profile. So it's not just for the fight or flight kids, although with Lucas it's been a real godsend.
Yeah, so definitely it's very helpful in those safety issues, but that's great bringing that up, Mary. I appreciate that. So one of the things that's also really, really helpful for is anxiety in individuals with autism. And, one of the things you want to do when you're evaluating anxiety in an individual with autism is really have an understanding of what is driving that anxiety. So if the person's able to talk to you about it, that's great. But even for individuals who don't have great or adequate verbal skills to kind of talk about that. And even people, who don't have autism, talking about anxiety can be really, really difficult. But, what you want to understand is this anxiety about the future or is it anxiety about the present? So what I mean by that is, are you someone who is worrying about, I'm going to get sick? What about this test that's coming up? Is there going to be a storm, right? Those kinds of things, future thoughts, right? Those are things that are very kind of traditional anxiety. They tend to be kind of driven by low levels of serotonin for most individuals. Traditional medications aimed at anxiety, like serotonergic drugs, for instance, you were mentioning Prozac, can be helpful. However, many people with autism don't have that kind of anxiety. They have the anxiety about the present, meaning, what's going to happen? Is there going to be, how many people are going to be there? Is it going to be too noisy? What is the expectation? Is it, are they not going to have the, the food that I'm really looking forward to? Am I not going to be able to predict this environment in a reliable way that's going to allow me to feel comfortable there? So that not able to adjust to the variations in the environment, and our environments are constantly changing, right? So, and that tends to be my experience has been that's the kind of anxiety that people with autism experience more frequently or more strongly. That seems to be the one that's really the barrier, that they're resistant to going to a place, not because they're worried that something's going to happen there. It's more, I can't predict this environment. I don't know what the expectations are there.
Yeah.
And where the propranolol can also, or a beta blocker. So this larger class of medications are beta blockers. I just tend to use propranolol a lot because that is the most widely studied in individuals with intellectual and developmental challenges, and autism. The literature for autism is starting to come out very nicely. So, that's just my first go-to. But
and
it's really.
I remember when you put Lucas, when you prescribed it for Lucas, you said you had 40 individuals, and all of your patients have autism. You are like almost exclusively autism now, but you had 40 back 5 years ago that were being treated, and now you have many more people that you're treating with propranolol, right? As a medication.
So it's so like you said at the beginning of the show, this isn't the answer for everyone, but it is a useful tool for many people with autism.
Yeah. Okay, so the other thing I wanted to get the word out about is a metabolic pharmacological test that you recommended. I don't know if I'm describing it right, but the test that we did, which I described in my video blog on Should You Medicate Children with Autism, was from genomind.com. But I found that was really, especially with my background in the healthcare profession and being a BCBA, it's like more people need to know about this. More physicians, more general pediatricians, more psychiatrists. I've recommended it to a number of people who, one of my friends had a typically developing teenager that tried to commit suicide, ended up on a cocktail of meds. It's not just for people with autism, but it does provide, I think, a lot of knowledge. So can you talk more about that test briefly and tell people what that is?
Yeah, sure. So the test is generally what we call pharmacogenomic testing. So it is looking at someone's individual DNA to predict how they may react to medication and how they may metabolize medication. So there's two different things that we're looking at. So the science has kind of evolved to the point that we have a good understanding of certain genes that code for certain receptors. For instance, so we've been using Prozac today, so let's just keep talking about Prozac. So Prozac is an SSRI. We know that it's meant to interact with the serotonergic transporter in the brain. We know what the gene is that codes for that. We also know that there are variations of that gene, what we call the long and the short form of the gene. So if you have the long form of the gene, that's beneficial for having a good response to the medication. If you have a short form of that gene, it's not likely that you're going to have a good response to the medication. So you get a copy of the gene from each parent, right? So people have long form from both parents. They're likely to have a very nice response to the medication. People have a long form and a short form. One parent gave them the long form, one parent gave them the short. Then maybe not great, but still some response. If you have a short form and a short form from both parents, very unlikely that you're going to have a strong response, right? And then you just saved yourself months of trying a drug that is not likely to be of super benefit, and you just move on to other classes of medications that are more likely to be beneficial. So it saves a lot of time and it creates a lot more efficiency. But then kind of what we were talking about, the metabolics, it's just important to understand. So every medication gets metabolized by our liver. So when we take it in, it needs to go through our liver once, and it kind of gets turned from the inactive form to the active form. That's the first stage of the metabolism. Then it kind of circulates through our body and kind of goes to the brain or wherever it's supposed to go. And then on its way out, it gets metabolized again and sent out, through, our urine and other, stuff. So, But then kind of understanding those pathways, just real quick, is if you have a really fast pathway, drugs are going to be going out of your body more quickly than you expect. If you have a slow pathway, they're going to go more slowly. And knowing those two things is really important to understand how you may need to dose a medication. So, having a fast pathway means that you may need to go up on the medication in order to get the desired effect, whereas having a slow pathway where you need to go low on the dose so that you avoid side effects.
Yeah. So a couple things, just in layman's terms. So when you recommended this drug test, it was a swab test. So it was non-invasive, just getting some swab out of Lucas's mouth, and then sending that away. And then then the report comes, and it's pretty much all the medications anybody could be on, not just kids with autism. So it's the antipsychotics, but it's the old antipsychotics and the newer antipsychotics. So in terms of what Lucas's test showed, it showed that he actually was good. Then it rates him in a red zone, like not good, yellow zone maybe, and green zone, meaning good. So the older antipsychotics like lithium and Haldol were older antipsychotics. He was in the green zone, but the Abilify and the Spiridol were in the red zone. And that's probably why we had so many problems. But it's not just psychotropic drugs. It's seizure medications, pain medications, over-the-counter medications, cardiac medications. So this is basically Lucas's response to all medications. And not surprisingly, but Inderal, which Lucas, we all agree, has been a really good med for him, was in the yellow zone because he was a rapid metabolizer. And that's why he didn't do well with long acting. And that's why we have to give it to him 4 times a day. But if it's going to keep him calm and have one aggression in 2 years, which we could kind of attribute to other things, then it's great. Then we can use that test. If God forbid he develops seizures or something, then we can go back to that test and say, instead of just trial and error, because the other point I wanted to make is you're like, it saves time. Our kids can't tell you that there's side effects, usually. Right. The kids with severe language problems like Lucas. So he can't say like my mouth is dry or I'm getting ringing in my ears or whatever. So it's like, I think it's really important. But the other thing I wanted to mention was you said that because our insurance covered it. Otherwise, it would be like $4,000. So you want to make sure that your insurance covers these things and that it needs to be ordered by a physician too, right?
It needs to be ordered by a physician. Insurance carriers are starting to recognize the value of this because in the long run, it does save them money. So they're getting better about covering. They're getting better about covering, especially as a one-time thing. And that's the other thing. It only needs to be done once because Lucas's DNA will always be his DNA. It's never going to change. So, this information is good for that person through the remainder of their life. Certain companies like Genomide and GeneSight are two of the most common ones. They're very good about when new gene discoveries are made, rerunning the person's sample to update that information so they, and then we get information like, we just want to update you on your patient about these 4 new genes that we've discovered and here are their results. So even though the gene discoveries keep happening.
Yeah. So it's Genomind and GeneSight.
Yeah. There's the 2 most common around here.
Those are the testing services that you run these swabs. Okay, cool. All right, so we're getting towards the end. So one of my goals for the podcast is to give strategies to parents and professionals to be less stressed and lead happier lives. And I know as a parent yourself of a son with autism, as well as treating, all of these patients over the years and having the opportunity to meet a wide variety of parents. Are there any top 2 or 3 things that you think would be strategies to help parents and professionals be less stressed?
So I think one of the things I'm going to suggest that's going to may seem counterintuitive because it's probably going to be more stressful at first, but really starting to think about the future is important and planning ahead. So I'm sure you agree with me, Mary, that it seems just like yesterday our boys were, those young little kids at that school, and now they're young men, and the time goes by really quickly, and and I certainly understand that sometimes things are at a point where you're just thinking about how you're going to get through this week, never mind what's coming up in the next few years. But when you have those opportunities where things are calmer and things seem to be going reasonably well, you feel like you got a handle on it for the moment, think about what may be coming down the road, because autism is a developmental disorder, right? We all change as we develop through our lifespans. We know people with autism struggle with development, so there's going to be struggles just like there is for the rest of us, but we need to think about what that next stage might be for them. So spending some time to thinking about what might be coming down the road is helpful. And I think the people who I think kind of weather the storms the best are the ones who kind of thought about the storm coming. So I think that's my counterintuitive is, kind of think about when things might not be so, it might be a little bit more rocky than it is right now is number one. Number 2 is celebrate every success, So, one of the things that, everyone who loves someone with autism understands that their successes are not the traditional ones, so it's not going to be, winning the award at school, perhaps, or it's not going to be, a thrilling sports performance, perhaps, right? It may be that, they said, a word for the first time, right? And that, that's a huge thing. And I feel sometimes parents kind of hold themselves back from celebrating those huge wins because it's not the traditional win. But you should shout that from the rooftop. That's that's amazing, right? Even more amazing than winning the state championship. So definitely celebrate those moments. And the third one is everyone needs a break. So when it's important to invest in yourself and invest in your relationships outside of your relationship with your child with autism. So really, and it's not a luxury. A lot of times, like, I don't have that luxury, or I feel selfish doing that. And I kind of tell people sometimes, I'm prescribing this as part of your son's treatment that you need to take a week in a way. That that you need to recharge your batteries so that you can kind of get back in there and be the support that he or she needs. And sometimes our children need a break from us, right? So particularly as they're starting to get older. So really kind of, and whatever that break may look like, even if it's a couple hours in the afternoon, take that time for yourself, doing something that allows you to have that sense of identity outside of being a parent of someone with autism, because it's really important that we have balance in our lives.
Yeah, I think that's great. So how can parents, professionals, physicians, how can they learn more from you? And I know you have like a whole plan for more research in this area, and how can they keep in touch and see where we go from here?
Sure. So I think there's a couple of things. One of the initiatives that I'm involved in for the state of Pennsylvania is something called ASSERT, which stands for Autism Service Education Resources and Training. So I do a lot of work there. So that website is paautism.org. So a lot of our educational and outreach materials go up on that website. My research efforts are on the Penn State Autism Hub. So if you just go on the main Penn State website, psu.edu, and just in the search bar go autism, that hub will come up, and then it kind of links out to not just me but other really interesting investigators across the university. And there's some really very cool things being done across the university. So highly recommend that as well.
Great. So I really appreciate your time today. I think I've been wanting to spread the word about, that psychiatry with autism is more than just the couple of medications that are FDA approved for children with autism, and that, we need to look at each individual and really striving to get each individual to reach his or her fullest potential. So I've really enjoyed this talk. I know you're a big proponent of multidisciplinary team approach and a great doctor for our kids and adults with autism. So thank you so much. And really, you can go on my website to get some of the links that Dr. Murray has provided, and you can go right to the show notes at marybarbera.com/podcast. There's also a free online workshop you can attend if you're a parent or professional, and that gives you more information about my online courses. So that is at marybarbera.com/workshop. Thank you again, Dr. Murray, and I hope that you all tune in next week for another episode of the Turn Autism Around podcast. Thank you.
Thanks.